In this MiniCex video, I shall take you through a case of acute right upper quadrant pain of the abdomen, the clinical features of his presentation, the investigations, diagnosis, and management. Today, the patient is Mrs. K, a financial officer in a factory in Sungai Petani. She narrates her history. I am a 49-year-old presenting to the emergency department at the Hospital Sultan Abdul Hamid in Sungai Petani with a one-day history of persistent severe right upper quadrant pain and vomiting. The pain came suddenly shortly after my evening meal consisting of fried kway teow and fried chicken wings. This was followed by intermittent bouts of bilious vomiting but no blood. The pain was severe and dull in nature and radiated to my right shoulder and to the back. It worsened over the few hours and was not relieved by my usual Panadol and gastric pills. It was aggravated by food with no relieving factors. I also had a fever but no chills or rigors. I did not notice any yellow discoloration of my eyes, skin, and my urine and stools were normal. I had similar mild pain at the right upper quadrant on and off for the past 3 months. It used to be exacerbated by fried food and relieved by gastric pills. My GP said I have gastritis and prescribed some gastric pills which gave some relief. I did not have any chest pains or breathlessness but unable to take breaths due to pain. I am a diabetic for the last 2 years and I am concerned about my blood sugar as I have not been able to eat a normal diet since the pain started. I open my bowels normally and have no urinary symptoms. I also have high cholesterol and I am on rosuvastatin 20 mg daily, and for my diabetes I am taking metformin 500 mg BID with sitagliptin 100 mg daily. I have no family history of similar problems. My husband and 2 children are all healthy. I take a normal Malaysian diet but prefer fried food which I consume frequently. I do not smoke or consume alcohol and I go regularly to the gym near my office for physical workout. So the main points in the history will be a 49-year-old female, right hypochondrial pain for 1 day, severe and sudden with vomiting and occurred after meal. Fever, past history of 3 months pain, patients are diabetic, hyperlipidemic, but no jaundice or chills. Okay, these are the questions posed to you after the history. What has the patient has a history of mild pain in the right upper quadrant for 3 months. What is the significance of this pain? It suggests the patient has cholecystitis and possibly chronic cholecystitis. Question number 2. Why is she unable to take a deep breath? This is due to an inflamed gallbladder which comes into contact with the diaphragm each time the patient takes a deep breath. Question number 3. What is the significance of the patient being a diabetic? Being a diabetic has a higher risk of complications and these tend to be also more severe. Question number 4. What are the possible differential diagnoses from the history? These are biliary colic, acute cholecystitis, acute pancreatitis, and perforated peptic ulcer. Next, we come to the examination of the patient. The patient is in pain and febrile with a temperature of 38 degrees Celsius and a pulse rate of 116, and she is not clinically jaundiced and no pallor. On examination, of the abdomen, she is found to have tenderness and guarding in the right upper quadrant, which is worsened by placing two fingers beneath the tip of the 9 costal cartilage during inspiration. A tender mass is palpable in the right upper chondrium. It was soft and moves with respiration. The heart and lungs are normal, and review of the other systems are also normal. The urine is clear and rectal examination is normal. So summarizing the main points in the examination: patient in pain with high fever, tachycardia, and tenderness and guarding in the right hypochondrium, with positive Murphy sign and a tender mass in the right hypochondrium. What is this clinical examination being performed on the patient, and what is the test used to detect? This clinical examination is palpation of the right hypochondrium to detect for tenderness. It also is a test to detect whether the Murphy sign is positive or otherwise. Now we come to some questions on examination. Question number 1. The patient has a temperature of 38 degrees Celsius but no jaundice. What does this imply? It implies that the patient may be having acute cholecystitis and not a common bile duct stone with cholangitis. Question number 2. Tenderness and guarding elicited especially on palpation below the 9th costal margin. Why? This is a positive Murphy sign, which is due to an inflamed gallbladder hitting the palpating fingers on deep inspiration, causing severe pain. What is the tender mass in the right hypochondrium? This is a inflamed gallbladder forming an mass with the omentum with the gallbladder. What is your clinical diagnosis? Acute cholecystitis. Okay, now please give a clinical summary and the diagnosis. The summary is: a 44-year-old woman presents with a sudden onset of acute severe right upper quadrant pain in the abdomen for 1 day associated with vomiting and fever. She admits having similar milder pains off and on for 3 months. She is a diabetic, and on examination she is febrile with tenderness and guarding in the right upper quadrant. Murphy sign is positive. Jaundice is not detected. The provisional diagnosis with this clinical situation is an acute cholecystitis due to gallstone. Differential diagnosis will be acute gastritis, perforated peptic ulcer, acute pancreatitis, and choledocholithiasis with cholangitis. Now, what are the investigations you will do for this patient? As a guide, these are the investigations you should do. Okay, based on your diagnosis from the history and examination, what investigations will do? What are the blood investigations, the urine investigations if any, and imaging and with or without biopsy, and any special tests for this patient and others which you may want to include. Okay, this is the blood investigation for the patient. Comment on the blood tests done on the patient. Okay, these are the full blood count. This is the renal function test. These are the liver function test. You also have the serum amylase test and blood glucose. Okay, these red arrows show the investigations that are deranged. Total white count is 18,000, which is increased. Aspartate transaminase or AST is also elevated millimole. Bilirubin is increased slightly. Blood glucose is also increased as the patient is diabetic. Alkaline phosphatase is within normal limits, suggesting there is no obstruction of the bile ducts. So this is a picture of leukocytosis, hyperglycemia, and mild bilirubinemia, okay, with slightly elevated liver enzyme. So a reasonably normal liver function is indicated by these results. Now, coming to the imaging. Let's see, the imaging that you want to do will be chest X-ray and ultrasound. Okay, this is a chest X-ray of the patient. Comment on this chest X-ray. The chest X-ray is quite normal. The lungs are clear. The trachea is central. The heart is normal, and the diaphragm are almost at normal levels. This is an ultrasound of the patient. This is the gallbladder, which is distended. There are stones within the gallbladder suggested by this hyperechogenic echoes within the lumen, casting a posterior shadow. And the wall of the gallbladder itself is thickened with pericholecystic fluid, suggesting it is acutely inflamed. So from the ultrasound of the abdomen, we can say it is in keeping with acute gallstones with acute cholecystitis. So the final diagnosis from the clinical considerations as well as from after the investigations is acute gallstone cholecystitis. Next we come to the treatment of the patient. Outline the principles of management of this patient. Okay, first the initial treatment consists of intravenous fluids and electrolytes, followed by analgesics such as opiates such as pethidine, antibiotics such as cephalosporin plus metronidazole, surgery which is cholecystectomy, which can be either laparoscopic or open. Next we come to some general questions about this case. Whose sign is elicited on examination of the abdomen? The answer is Murphy's sign. What is the most likely diagnosis in this patient? Acute biliary colic or acute cholecystitis from gallstone disease. What is your treatment? IV fluids, analgesics, antibiotics, followed by surgery, cholecystectomy, either laparoscopic or open. Question number 4. How would you treat the high blood glucose in this patient? By using IV insulin titration against the blood glucose. And the final question, number 5. What specific complication is the patient at risk? Okay, she is in particular risk to develop empyema of the gallbladder, gangrene, and perforation of the gallbladder with septicemia. Okay, in summary, acute cholecystitis is one of the conditions in the whole spectrum of the diseases of the biliary tree. This whole spectrum consists of asymptomatic gallstones or cholelithiasis, biliary colic, acute cholecystitis, chronic cholecystitis, choledocholithiasis, and cholangitis. Okay, this slide shows you the demonstration to elicit the Murphy sign, which is a very important sign for medical students. The patient is lying supine, and then you ask the patient to exhale. The examiner places the hand below the costal margin on the right side, at the mid-clavicular line. The patient is then instructed to inspire as you press in that area. The positive Murphy sign is when the patient stops breathing in and winces with a catch in breath during respiration. And this is due to the inflamed gallbladder being palpated as it descends on inspiration. Okay, these are some X-rays which are taken to rule out the differential diagnosis. First, the most important is a chest X-ray, an erect chest X-ray, which should really demonstrate an elevated right hemidiaphragm in a case of liver abscess. It may also reveal a lower right lobar pneumonia, which can be the cause of this pain, and also it can exclude pneumoperitoneum due to perforated peptic ulcer with air under the diaphragm. Okay, these are the chest X-ray findings in the various cases that can mimic acute cholecystitis. Okay, this is a ultrasound image of a normal gallbladder. See, the gallbladder is filled with hypogenic bile inside. There are no stones and the wall is normal, not thickened. Okay, this is a normal gallbladder. Here, the gallbladder, it consists of, there's a stone within the gallbladder, and this stone is a hypoechogenic focus within the gallbladder, and it casts a posterior shadow. Right? This is a features of gallstone, and here another gallbladder with a stone within it and casting a posterior shadow. Whereas this slide shows you an X-ray picture of a gallbladder that is acutely inflamed. See, there's thickening of the wall. Okay, there's pericholecystic fluid surrounding the wall of the gallbladder. Multiple stones within, casting a posterior shadow. Okay, this posterior shadow confirms it is stones. Okay, so these are the features of a inflamed gallbladder. Okay, what's the take-home message from this short session? I've tried to take you through a clinical case of acute cholecystitis, the symptoms and signs of acute cholecystitis, the differential diagnosis, provisional and differential, the investigations that must be carried out to confirm the diagnosis, and also the treatment, the outline of the treatment, general and definitive. More to read up for more details: cholecystectomy, laparoscopy, open and early versus delayed cholecystectomy, and others such as complications of acute cholecystitis and cholecystectomy. Thank you for your patience and hope to see you again in another session.